Good afternoon. My name is Sharonda Williams Simmons. I'm the communications lead at National Center for Primary Care at Morehouse School of Medicine. And the HIT Division's Hybrid Solutions presents Medicaid Promoting Interoperability Stage 3, Target What is Important. And we also want you to connect with us at highbridges.org and on Twitter with @HIB_solutions.
Good afternoon, everyone. Thank you so much, Sharonda. My name is Selena Williams. I am the program manager for the Medicaid Promoting Interoperability program here at Hybrid Solutions, formerly known as GA-HITEC. Nothing's changed but the name. So you often wonder who we are, what do we do, what kind of services we provide. We provide technical assistance to assist our providers across the state of Georgia to promote interoperability. Our goal is to help providers successfully transition to value-based clinical modules and healthier patient outcomes. We're located on the campus of Morehouse School of Medicine within the National Center for Primary Care. Carmen L. Hughes is our executive director, and Dr. Dominique Mack is the executive medical director. Our partners are DCH, Department of Community Health, GA-HITEC, DXC Technology, Myers and Stoffers, and various healthcare systems in the state of Georgia. Joining me today will also be Francine Jackson, the outreach representative with DXC Technology. So we're going to go into the objectives for this webinar today. It is to review Stage 3 objectives and measures, review documentation requirements and common errors for Stage 3, address frequently asked questions, discuss any challenges providers may be facing while testing for promoting interoperability Stage 3. EHR Software Updates. A provider must use technology that is certified to the 2015 Software Edition. The 2015 edition, CHITEC, do not have to be implemented on January 1st, 2019. However, the functionality must be in place by the first day of the EHR reporting period. The product must be certified to the 2015 edition criteria by the last day of the EHR reporting period. So to those who have not updated their software, we are moving into the last 90 days of the year. So please reach out to your EHR vendors and have them to update that software as soon as possible. So stage 3 is finally here. I know it's been in the talks for the last couple of years. We've been attesting to modified Stage 2 for the last few years. And with the thresholds being so high and the challenges with Stage 3, of course they push back, but this time we're going full speed ahead. It's here, we're ready, so we're here to assist. And so manage your measures and thresholds is very important. Registries, your security risk assessments, CDSR screenshots, and patient volume calculators. So the number one thing is the most important is to make sure you manage your dashboards to view your passing and failing measures. If you have any issues, reach out to your EHR vendor or reach out to us. We can assist. So it's very important that you check that on a weekly basis every 2 weeks to ensure that you are passing all the measures. So we're going to go ahead and go into some of the objectives and measures for Stage 3. Protect electronic health information. That's the first objective. That's your security risk analysis. It must be done once a year within the reporting period. The security risk assessment, the mitigation plans, and dates. It must be done and saved as the current attestation year. So once you've done that and you're completed with the mitigation and the plan, please save that as program year 2019, Stage 3. And store that somewhere in case you're audited and you need to get access to that information. So that's very important that you save this in a place that you can reach in case needed. The second measure is e-prescribing. As you see, that threshold has gone up tremendously. It's 60%. Well, it went up 10%. It was 50% in modified Stage 2. So that's when the providers are doing e-prescribing to their patients and sending it to the pharmacy electronically. That's how that will track within your EHR system. The third measure is clinical decision support. There's 5 rules that are reflected in 4 or 5 CQMs and are relevant to the practice or high priority health conditions. So you would choose these screenshots that matches your clinical quality measures. You have to choose 6 when reporting for 90 days in 2019 stage 3. So you're going to choose these clinical quality measures, and you're going to take screenshots and save those. It has to be within the 90-day reporting period. So I have some examples will be hypertension, anything that will prompt the provider to make a decision, a clinical decision, that can be an alert. Or you can have order sets set up in your system that will also suffice as a clinical decision support if you do not have that supporting documentation for the clinical decision support. So CDS rules, order sets, those all will qualify for you being able to attest and use for that objective 3. The drug and drug allergy interaction is something totally different. It's part 2 of this objective, and some people always ask if they choose the clinical decision support rules, do they have to enable the drug to drug allergy? That must be enabled. I'm sure that functionality is in your system. It may not be turned on. So reach out to your EHR vendor and have them to turn that functionality on to enable drug to drug allergy. And some of its experience that I had with one of the providers, they were doing the e-prescribing. That loops back around to the e-prescribing. They was doing the e-prescribing. However, the that functionality was not enabled, so it was not checking the eligibility for those prescriptions, which caused her to fail that measure. And because of that one button that was not clicked, she was not able to attest, because of course it's either all or none. So by the time she was able to reach out to the EHR vendor, it was too late for her to go back and have that fixed, and she wasn't able to attest. So that's why it's very important that you check your dashboard to ensure that all the functionalities are working and all of your measures and objectives are tracking through your EHR system. Objective 4, there is 3 parts to this. This is the computerized physician order entry. That has also increased. It is 60% of your medication computerized physician order. It is 60% for the labs and also 60% for the imaging. So this has to be done when an order is done. It has to be done through your electronic medical record, HR electronic health record, so it can track within the system. If it's not tracking in the system, then like I say, you need to reach out to the EHR vendor, because in order for it to calculate, it has to track in the system. It can't be faxing it. You will not get credit for faxing this information. It has to be done. The order has to be ordered within the EHR. 5, patient electronic access. This measure is 80%, and this is timely electronic access within 48 hours. When a patient walks into a physician's office, they are given access to their specific health information, and either them given access to them or authorized representative that can access their records on their behalf. So this is done through giving them a username and login to access the patient portal. And the second part is it can be accessed through an API, and this is through an interfacing that you may have set up with your EHR vendor. Also, patient-specific education, this must be available on the portal. So anything that the provider gives you pertaining to your diagnosis, they can send that patient education on hypertension, diabetes through the patient portal, and it tracks. It must be at least 35% or more of your patient encounters. So we're going to go into the next 3 objectives. Now we know that there's 8 objectives, so 6, 7, and 8, I'm going to go into those a little more in depth because there are a lot of measures that entails these objectives. Sorry, let me go back. So 6 is coordination of care through patient engagement. They reduced this percentage on this particular objective because it was a challenge for providers to meet this. So on this objective, providers must attest to all of 3 measures and must meet the thresholds of at least 5% for at least 2 of these measures. So 1, Provider must give patient or authorized representative access to their medical record by creating a user ID and password, view, download, and transmit. So they must actually go onto the patient portal. The first one that was patient electronic access, that was giving access to the portal. On this measure, the patient must go on there and view their labs or download or even transmit a message to the provider with communication in order for it to track, and it must be more than 5%. Part 2 is secure messaging through the portal. As I mentioned, that's also sending a message. I think I just said that in 6.1. So they must go in and send a message to a secure message through the messaging function to the patient or authorized representative. 6.3, the patient-generated health data or data from a non-clinical setting is incorporated into the EHR for more than 5%. For example, any health data, patient education about your diagnosis, hypertension, diabetes, or whatever the diagnosis is, this must be incorporated within the EHR system in order for it to track. Health information exchange. This is a big one. There's services out there to assist with providers to meet this measure. We have services that we offer, and some of the services cost, and we also have costs in place to offset, pricing resources in place to offset some of the costs. So health information exchange, the EP provides a summary of care record when transitioning or referring their patient to another setting of care upon the first patient encounter with a new patient. So when that patient comes in to see the provider and they refer them out to a specialist, they must create a summary of care, and it must be done electronic. They must create it and send it out in order for it to track, and it must be more than 50% of the patients. So that's a high percentage. So whenever it just should be automatic for the provider to attach that summary of care when they're referring the patients out, or the MA or whoever, the clinical staff that does this. So provider must create that. And measure 2, they must receive a summary of care document electronic and incorporate into the patient record for more than 40%. So that one is 10% less, but receive the summary of care document for referrals through the direct secure messaging. And of course, you can exempt that if you have less than 100 patients within the reporting period. But if you have more than 100, then you must attest to this measure. Part 3 measure for this objective is clinical information reconciliation for more than 80% of the referrals received. And this, they say new patients, but it should be done. I recommend that you do it with every patient that comes through the office. That way you know it's tracking. So for example, medication reconciliation, they must review the name, the dosage, and frequency, and the route of each prescription. They must review the medication, allergy, and correct problem list, which is usually done by the MA during the initial workup. So this is something that should be done during the initial workup with every patient. But they're saying that it should be done within a new patient. But just for clinical workflow, this can be done with all the patients that are checked in. And on this objective, even though the measure states, okay, yes, I just said that. Okay, so objective 8 is the public health clinical registry. These are also a little challenging. I know with modified stage 2, there was only 3, but we have 5 different registries and measures that we have to meet in order to be able to successfully attest for promoting interoperability. So the provider must actively engage in a public health agency or clinical data registry to submit electronic public health data using the EHR. The EP must satisfy at least 2 of these measures for this objective. So there are 5, but you must meet at least 2 of them to satisfy this measure. They may take an exclusion from all measures that they cannot meet. So the first one is immunization registry. The provider must be actively engaged with submitting data through GRITs and receiving immunization forecasts and history. So when the patient comes in for immunization, this data must be transmitted through GRITs. Most providers already have interfacing in place to track this measure. Measure 2 is syndromic surveillance, which in the state of Georgia, we do not have, the providers do not have to attest. So usually you would get an exclusion letter from the syndromic surveillance, and we have that step-by-step that's needed in order to receive that letter, because the state is still asking that you submit that information. So you will send an email to the state and they will send something back saying that you're not required to submit this data, and that information will be sufficient to submit as your exclusion for that measure. Okay, so measure 3, electronic case reporting. This is a new measure. The EP is an active engagement with a public health agency to submit case reporting of reportable conditions. They may exclude if he or she does not diagnose or directly treat any reportable diseases for which data is collected by their jurisdiction. So reportable diseases during their EHR reporting period. He or she practices in a jurisdiction for which no public health agency is capable of receiving case reporting, or he or she where no public agency is declared readiness to receive this information. So if there's not a public health agency that is up and running to receive this information, you can attest, you can take the exclusion on this measure as well. Measure 4 is the public health registry. The EP is active. The EP must be actively engaged to submit data to a public health registry. The exclusion would be the same as the one before. If he or she does not diagnose or directly treat any diseases or conditions that are associated with the public health registry, they can take that exclusion as well. And the last one on this is the clinical data registry, which those are a little confusing. So the clinical data registry is the EP is actively engaged and must be able to submit the clinical decision registry. If they do not diagnose or directly treat any of these diseases, then they can also take that measure. So remember, you can take, you have to test the 2 of them. You know you'll be taking the exclusion for syndromic surveillance. So you would need to pick one of the other: electronic case reporting, public health registry, and clinical data registry. And these registries are specialized registries. So for example, if you're a cardiologist, if you report any of those diseases to a cardiologist, then you should be able to get something from that registry. And we also have that information, a list of registries that you can contact. And as I mentioned, we are in the last quarter of the year for reporting. So it is very important that you guys continue to check your dashboard, check your measures to make sure you're meeting these measures. Reach out to us, reach out to the public health, go to the public health website to see what registries you need to register for, and to ensure that you are meeting these objectives and measures. These months are rolling by fast, so we want to make sure that you are successfully getting this done. So I'm going to pass it over to Francine. She's going to go in, Francine Jackson with DXC Technology. She's going to go over some of the commonly used errors when attesting and uploading your documentation.
Thank you, Selena. That was some very valuable information. Now, the first document I'm actually going to go over is the detailed encounter report. We prefer that the detailed encounter report is in an Excel format. It must include the date of service, also the provider's name, unique patient ID or patient name. It also needs to include the information to show Medicaid paid for Medicaid encounters, or in other words, like type of insurance. It also can include both paid and denied claims. The next thing we're looking for is your patient volume calculator. It needs to include either the current year of 2019 or the previous year of 2018 patient volume. You also need to have the security risk assessment, which is a HIPAA requirement. We also need to have screenshots for any yes or no measures. Also, any documentation that you may have for the exclusions that you take. And also for the Promoting Interoperability Summary / Dashboard Report. These are going to include all the objectives and measures that you are attesting to. And the last thing we're looking for is the verification of use letter certification number. The letter is no longer an upload requirement. You only need that number, which is a certification number, to enter into your MAPR application. The next thing we're going to talk about are the common provider attestation errors. Providers, you will need to make sure that you're paying attention when you are entering your applications. We find that a lot of providers make errors, basically not paying attention or not correcting the information that's in GAMIS or on the CMS National Level Registry. The first error we're going to talk about is the incorrect payee 10 and NPI. If you see this error, this basically means that you've actually entered the incorrect 10 and payee NPI. You would actually, if you have something different on the GAMIS website versus the 10 and NPI, if it's different than what's in the CMS National Level Registry, then you're going to get this message. Now, with this message, you can actually hit the continue button to go to the next screen to continue with your application. However, if you do not correct this error, then you will actually, and you hit, if you do not correct the error and you hit submit to submit your application, then you may not get you will not get paid until the next program year. In other words, you won't be able to attest until the next program year. So make sure that you are checking GAMIS and CMS to make sure that the payee 10 and also the NPI matches exactly. The next error that we have is the mismatch error. If you take a look at the screenshot, you see where it says information from Georgia Medicaid versus information from the National Level Registry. Again, as I stated earlier, both needs to match exactly. For the Social Security number, we see that the last 4 digits of the social are correct in the Georgia Medicaid and NLR, but keep in mind that there's some part of the Social Security number is not matching, and it's not going to show the actual full Social Security number on this screen. You would just basically need to check GAMIS and the National Level Registry to see exactly what Social Security number that you actually put in. Also, one of the common errors that we actually find with providers is the zip code. A lot of times providers, you will actually just put the first part of the zip code. However, there may be an extended part of the zip code. As you can see here in this example, in the Georgia Medicaid, the extended zip code is 2493 versus what you have in the National Level Registry, which is 2467. So make sure that information is correct as well. Another error that we'd actually see with providers is when it comes down to spelling street, S-T-R-E-E-T, versus the abbreviation for street. If it's spelled out in GAMIS, it needs to also be spelled out on the National Level Registry as well. The next part we see here where it says current service location, we see that the provider is logged into the A location. However, if you look right below there, it says service locations currently able to access Mapper. If you can see there, it says the B location, and it says has existing applications. It says yes. So you know at this point, you'll need to log out of the A location and log into the correct location displayed on this screen, which is the B location. The next error we have here is the yes or no button. When you first start the Mapper application, you're going to actually start where it says the Get Started button. On this page, it's going to have the provider's address, NPI number. Give it 1 second, it's still switching over by itself here. Okay, so it's going to have the address, the NPI number, the 10, all that information needs to match to what you have on the CMS National Level Registry. Now, if you take a look at the buttons at the bottom, you're going to see a yes and no button. If you click yes, that means that you are certifying that the information that you have entered onto the Mapper system is the same as what you have in the CMS National Level Registry. If you click no, that means you'll need to make an update somewhere. You need to make an update on the CMS side to match what you have in the GAMIS system. The next error we have is the incorrect RNA number, which is the registration attestation number. This is that same number, which is that 1000 number that you actually registered for at the beginning of this program on the CMS National Level Registry. Some providers, however, forget exactly what number, what that number was. If you need to go back to find out your RNA number, you can log back onto the CMS National Level Registry. However, once you come out of there, you actually, in other words, go all the way to the end of the application and hit submit to come out of it. You will have to actually wait 48 hours before going into Mapper to continue your application. The next error we have here is the incorrect provider ID used. A lot of times providers may forget exactly what provider ID they actually registered Mapper applications under. In this case, in this example, this provider did not have any applications. For example, like in the C location, they didn't have any applications registered under this program in the C location. The application actually had applications in the D location. So in other words, they should have actually logged out and logged back into the D location. All right, so that concludes the part for DXC Technology as far as the errors and the documentations needed. And now I'm going on and turn it over to Sharinda, where she'll go over the announcements.
Thank you so much, Francine. That was Francine and Selena. That was a lot of great information. And obviously, Hybrid Solutions is a great source for getting more information about this. So if we're going to go to our next slide so I can read off these announcements. And now we're going to go on to our Q&A. We got some really great information and great questions from you all during our registration as well as during our session right now. So what I'm going to do is I'm going to open up the line to answer Michelle Mendoza's question. And that is, what do you recommend for the generated health data, timely electronic access, and patient-specific education?
Okay, thank you, Sharinda. Ms. Mendoza, you can reach out to your EHR vendor and they will have some recommendations as to some resources that you could use. There may be an additional cost. I have another provider that's going through the exact same thing, and she reached out to her EHR vendor and they recommended some resources that they offer.
Okay, awesome. And another one came in anonymously. What is the difference between timely electronic access and patient-specific education?
Okay, timely access is when the provider gives the patient access to the patient portal to go in to access the medical records. The secure messaging, is that what you said, Sharinda?
It is
patient education.
But yeah, patient education.
Patient education is when the patient sends patient education through the patient portal to the patient. So anything when you leave the doctor's office and the provider has seen you and went over all the patient education regarding your diagnosis, he can send something through the portal, some kind of education pamphlet through the portal for you to be able to read regarding that diagnosis. And it must be done through the patient portal. Or it must be done electronically, I'm sorry. And most of the time it's done through the patient portal.
Awesome, thank you for that. All right, we have another question. It says, I've missed attesting for a previous program year. Can I go back and attest for that year?
I can take that question. If you have missed attesting for a previous program year, you cannot go back and attest to that year. You have to only attest to the current program year.
Okay, so they can only attest to the current program year.
That is correct.
Okay, here's another question. If an eligible professional or EP in the Medicare and Medicaid Promoting Interoperability program is part of a group practice that has achieved ongoing submission to a public health agency, but the EP themselves did not administer any immunizations to any of the populations for which data is collected by the jurisdiction's immunization registry during their EHR period. The question is, can he or she attest to meeting the measure since they are part of the group practice that is submitting data to the registry?
Thank you, Sharinda. Okay, so if a provider does not administer the immunization, they should not attest for that measure. So what they should do, if they did not administer that in their practice, they should not attest to that measure. They must claim the exclusion. So if a provider does not attest but did not have any for a particular EHR reporting period, they are not required to claim the exclusion as long as they have done any necessary registration and testing or reporting when they do not have the data to report. So if you did not do it, you cannot report it. So you have to take the exclusion.
So can a public health agency use an HIE to interface with providers who are submitting public health data to meet the public health objectives of meaningful use, such as submitting information to an immunization registry, reporting lab results to a public health agency, or reporting syndromic surveillance information?
So there are a variety of methods for the exchange of public health information, and CMS does not limit or define the receiving capabilities of public health entities. So as long as the information is required by a public health meaningful use objective, PI objective, it must originate, as long as it is originated from the certification, a certified electronic health record technology.
All right. So for objective 1, protect patient health information, or EPHI, can a security risk analysis or review take place outside the EHR reporting period?
Yes, it can take place outside of the EHR reporting period. Most providers do it within a year. It has to be done in that year. It is acceptable for the security risk analysis to be conducted outside. However, the analysis must be conducted for the certified EHR technology used during the reporting period, and the analysis or review must be conducted on an annual basis. So in other words, the provider must conduct a unique analysis or review applicable for the EHR reporting period, and the scope of the analysis or review must include the full EHR reporting period. So they can start it outside the reporting period, but it must be completed before they attest.
Okay, before they attest.
Yes.
So we have a live question that came in from Ralph O'Connor. How you doing, Ralph? In the patient volume calculator, how do we report patient encounters that are eligible for both Medicaid and Medicare?
Okay, I'm sorry. I was thinking DCX was doing the patient volume encounter. Sorry, guys. I was only tuned in for measures. So I believe they're addressing, and you guys might want to help me out on this, I believe they might be asking about the secondary. Medicaid is a secondary, which is allowed to be counted. Francine, did you have anything you wanted to add with that?
I don't have anything I want to add with that.
Okay. So you can count, if somebody is there for, if you have a secondary for Medicaid, you are allowed to count that in your Medicaid totals as well. So that's good news. I hope that answers that question.
Well, Ralph, let us know if you have any more questions, and you can email one of these ladies right here, and we'll gather more information for you. You can see it at the bottom of this slide. All right, another question. Can the drug and drug allergy interaction alerts of my electronic health record also be used to meet the meaningful use objective for implementing one clinical decision support rule for the Medicare and Medicaid Promoting Interoperability programs?
Okay, so I talked about that when I was going through the objectives. The answer is no. So the drug allergy checks and the implementation of clinical decision support interventions are separate measures. EPs and eligible hospitals must implement 5 clinical decision support interventions in addition to the CDS drug and drug allergy interaction. So that functionality, as I mentioned in the presentation earlier, that functionality must be enabled, and the clinical decision support rules must be selected separate. It's 2 different measures.
Got it. And unless we have any more live questions, this is our final question. How do we show dual eligible patients, Medicaid and Medicare, in the patient volume calculator? I know this is kind of similar to Ralph's question, but how do we show dual eligible patients, Medicaid and Medicare, in the patient volume calculator?
Okay, yeah, that is similar to Raf's question. So it says, really, any provider that is dual eligible would need to go through the steps of completing a PVC to show proof of eligibility. So, of course, you would use your detailed encounter report as your guide to complete that. And it must be 20% for pediatricians and 30% for any other providers that are testing. So as long as you can show that proof of eligibility, you should be able to attest to both programs.
Okay. And just to answer Ralph's other question, can we get copies of these slides? Ralph, we will send out, and to anyone else who's wondering about this, we'll send out a link within the next 2 weeks, or we'll have a link within the next 2 weeks that will be on our website of this presentation. Okay. So it looks like we don't have any more questions, but if you happen to think of any questions, feel free to email Selena or Francine or Liz if you have her email as well. But Francine and Selena's are at the bottom of this slide. And if you want some more information about HighBridge and the change that has occurred with it going from HITEC to HighBridge, feel free to reach out and ask some questions about that. And thank you.